If you've been told hormone therapy for menopause is dangerous, you're not alone. After the Women's Health Initiative study came out in the early 2000s, a lot of women heard one simple message: hormones are risky, avoid them if you can. But that message left out a lot of important details. Which hormones are we talking about? Which dose? Is it given orally or transdermally? Synthetic or bioidentical? Are we talking about someone newly menopausal or someone starting hormones decades later? Because hormone therapy is not one thing. And when we oversimplify it, women can end up on either extreme. So women get scared away from treatment that may actually help them. Other women may get treatment without enough thought, monitoring, or follow-up. Neither extreme is where we want to be. So today, let's talk honestly about hormone therapy safety. What the WHI study actually showed, what it did not show, and why the details matter. Hi, I'm Dr. K. I'm a pharmacist and a clinician focused on weight loss, hormone health, and metabolic health. I use practical, evidence-informed approaches to help you better understand your body and make more confident health decisions. My sources are cited below, and remember, this is for education only. It's not personal medical advice. Before we talk about whether hormone therapy is safe, we first need to understand what we're treating. If you watched my previous video, you already know that perimenopause is the transition leading up to menopause. And during perimenopause, hormones are not simply low, they fluctuate. It's not always a straight downhill line. It's more like a roller coaster. And that's one reason treatment needs to be individualized. Because the better question is not simply, are hormones safe? The better question is, for this specific patient with these specific symptoms, using this specific hormone through this specific route and this specific dose, do the potential benefits outweigh the potential risks? That is a completely different conversation. If we're going to talk about hormone therapy safety, we have to talk about the WHI, or the Women's Health Initiative. This study changed the entire conversation around menopause treatment. One part of the WHI looked at postmenopausal women using conjugated equine estrogens plus medroxyprogesterone acetate. That part of the study was stopped early because researchers saw higher rates of several serious outcomes in the hormone therapy group compared with the placebo. That included invasive breast cancer, stroke, blood clots, and coronary heart disease events, which includes things like heart attacks. That finding mattered. It wasn't something to ignore. But here's the part that often gets missed. Those results came from that specific hormone combination in that specific group of postmenopausal women using that specific route of administration. In fact, the WHI authors acknowledged this limitation. They stated that the trial tested only one drug regimen, conjugated equine estrogens at 0.625 milligrams, plus medroxyprogesterone acetate at 2.5 milligrams. And that the results do not necessarily apply to lower doses, other oral estrogen and progestin formulations, or estrogen and progestin given through the skin. They also noted that transdermal estradiol with progesterone, which more closely mimics the body's normal hormone physiology and metabolism, may have a different risk-benefit profile. In plain English, even the study itself was not saying that all hormone therapy is the same. The hormones used in that WHI trial were not the same as many of the hormones clinicians use today. Conjugated equine estrogens are derived from horse urine and are not the same thing as human estradiol. Medroxyprogesterone is a synthetic progestin. It's not the same thing as human progesterone. And the estrogen was taken orally, which matters because oral estrogen goes through the liver first and gets processed differently than a transdermal estrogen. ACOG has stated that oral estrogen may increase blood clot risk, while transdermal estrogen appears to have little or no effect on that risk. So the WHI gave us important information, but the problem was how the results were interpreted by the media, the public, and parts of the medical community. Many women heard, hormones are dangerous. Many providers heard, don't prescribe hormone therapy. But the more accurate takeaway should have been, this specific hormone combination in this specific group of postmenopausal women showed certain risks and benefits, and we need to be more individualized. That nuance is what got lost. The WHI created fear, but the bigger problem was oversimplification. Current menopause guidance is much more nuanced than hormones are bad. The 2022 North American Menopause Society says that hormone therapy remains the most effective treatment for hot flashes, night sweats, and genitourinary syndrome of menopause. It has also been shown to prevent bone loss and fracture, and it should be individualized based on type, dose, duration, route, timing, and whether a progestin is needed. So if you've been told hormone therapy is always dangerous, that's too simple. And if you've been told hormone therapy is always safe, that's also too simple. The truth is much more individualized than that. Hormone therapy is not one thing. Premarin plus Provera is not the same as estradiol plus progesterone. Oral estrogen is not the same as topical estrogen. Ethinyl estradiol in birth control is not the same as bioidentical estradiol replacement. And a synthetic progestin is not the same as progesterone. Those are not small details. Those details can change how we think about safety. A bioidentical hormone has the same molecular structure as the hormone your body naturally makes. Estradiol, estriol, progesterone, testosterone, and DHEA can all be bioidentical. A synthetic hormone may act on similar receptors, but it's not always the same molecule. For example, medroxyprogesterone acetate can have progestin activity, but it's not human progesterone. Ethinyl estradiol and conjugated equine estrogens have estrogenic activity, but they're not the same thing as human estradiol. Now, that doesn't mean that every synthetic hormone is automatically dangerous, and it doesn't mean that every bioidentical hormone is automatically safe. Even bioidentical hormones need to be dosed and monitored carefully, because too much of any hormone can cause its own problems. But the molecule matters, the route matters, the dose matters, the patient matters, and the monitoring matters. So when I say that I prefer bioidentical hormones when hormone therapy is appropriate for somebody, I'm not saying that they're magic. I'm saying I want to use molecules that match what the body naturally makes, dose them appropriately, use the safest practical route, monitor carefully, and avoid applying risk data from one synthetic hormone combination to every form of hormone therapy. That's the difference. Now, let's talk briefly about commercial versus compounded hormones, because this also gets misunderstood. Commercial hormone therapies are FDA-approved medications, and some of them are bioidentical. Estradiol patches, estradiol gels, vaginal estradiol products, and oral micronized progesterone are examples. So bioidentical doesn't automatically mean compounded. Compounded hormones are custom-made by a compounding pharmacy, and they can be appropriate when customization is needed. Sometimes a patient needs a dose that's not commercially available. Sometimes they need a different delivery method. Sometimes they don't tolerate certain inactive ingredients like peanut oil. That's where compounding can be valuable. Now, compounded hormones aren't FDA approved as finished products in the same way that commercial medications are, and that matters. But I also don't like the blanket statement that compounded hormones are unsafe. That's way too broad. A properly operating compounding pharmacy that follows USP standards, uses appropriate ingredients, maintains quality systems, and compounds under appropriate medical direction is not some reckless environment. The issue is not commercial good, compounded bad, or compounded good, commercial bad. The real question is, are we using the right hormones at the right dose, through the right route for the right patient with the right monitoring? Let's come back to the main question. Is hormone therapy for menopause safe? The honest answer is, it depends. Hormone therapy is not automatically safe for everyone, and hormone therapy is not automatically dangerous. For one patient, transdermal estradiol plus oral micronized progesterone may make sense. For another patient, local vaginal estrogen may be enough. And for another patient, non-hormonal options may be the better starting point. And for some patients, hormone therapy may not be recommended because of their personal medical history. That is why this should not be treated casually, but it should also not be dismissed automatically. The goal is not to scare women away from treatment, and the goal is not to throw hormones at every single symptom. The goal is to make an informed decision. So, what if your doctor says, this is just normal? Here's what I want women to understand. Yes, menopause is normal, but suffering through menopause is not something that you're required to accept. Hot flashes, night sweats, vaginal dryness, painful sex, poor sleep, mood changes, and low libido may be common, but common doesn't mean untreatable. So if you're told that's just menopause and no one discusses treatment options with you, it's reasonable to seek a second opinion from someone who specializes in menopause care. That doesn't mean your doctor is bad. It may simply mean this is not their area of focus, and you shouldn't have to beg to be heard. And you should not be told just to deal with it. So is hormone therapy for menopause safe? The honest answer again is it depends. It depends on the hormone, the dose, the route, the timing, the patient, and the monitoring. The WHI study gave us very important information, but it was often applied too broadly. Hormone therapy isn't one thing. Commercial hormones can be useful, compounded hormones can be useful, bioidentical hormones can be useful, but none of them are automatically perfect, and none of them should be used without thought, monitoring, and follow-up. You should not have to choose between ignore your symptoms and throw hormones at everything. There is a middle ground, a thoughtful, individualized, monitored approach. Hormone therapy is not something to use casually, but it's also not something women should automatically be scared away from. And in the next video, I'm going to walk through the actual treatment options that are available, including estrogen, progesterone, testosterone, and DHEA, and how I think through and use them in real life. Because women deserve better than fear, confusion, and being told just to deal with it. Thanks for breaking it down with me today. I'm Dr. K, and if you found this helpful, give the video a like, share it with a friend or family member, and subscribe to the channel for more health topics broken down. And let me know down in the comments what topic you want me to break down next.